to speak about essentially help for children through the school system. I get a lot of questions. Dr. Raghav gets a lot of questions. Dr. Bhatia got a lot of questions regarding this. And we're not the right people, and we're not knowledgeable like she is about it. So we wanted her to talk about this at the beginning of the school year and just kind of give everybody a sense of how to maneuver the system.
So, I'm Reshma. I haven't met some of you before. It's nice meeting you today. This is my team. So my incredible team who's going to actually participate in this process. One of the things that I was going to make you do an exercise, but now that we're all seated, I'm not going to make you do an exercise. But actually, why not? Let's hold hands.
Let's hold hands.
Let's hold hands. And if we're standing, we'd all be leaning back. And it's the tension of each one's hands that keeps us here together. And that's how we actually take care of our kids, where we need to join hands, interact with everyone that works with our children, and make sure that we hold them together. And as parents, one of the things you've done, right from the time your children were sick, is hold them and nurture them and protect them. But when you were so busy protecting them, you had to expand. So you expanded it, and that's the team that you expanded it to. And now when your child's going back to school, at any single time, you need to expand it to include this part of the team. So, and the community as well. And so what I mean by that is that our children, when they're going back to school, have a whole lot of different concerns. They have concerns about, how am I going to manage? Do I know what's going on? I don't have any friends right now, because the experiences are so different. And if your experiences are different, you're going back to a world where you don't understand the people. And the people don't understand you. So how do you actually navigate that? And then the other part is, if you've got those children that you're encountering that had very different summer experiences, children with a chronic disease spend a large part of their vacations doing more disease and illness and treatment type of things in those therapies. And other kids are out having summer experiences where they come back and talk about the crazy summer camps that they had. Quite often, our kids miss that because we're so busy taking care of them. And those are the things that foment friendships and allow people to share. And when you go back after a break and your experiences are so different, finding common grounds to talk about things makes it more difficult. So there's a huge psychological component and a psycho-emotional component from that perspective. And then the other perspective is, how do we, as parents, actually let our children go? Do we wrap them up in bubble wrap and overprotect them and try to make sure that we've seen every single pitfall that could potentially affect them? Or is it that we figure out how to trust the system and let them go? And so that's one of the biggest challenges most people have, including me, when we send our kids back to school. And a parent with a child who's got more chronic illnesses and concerns, the concerns for you become a lot more pronounced. One of the things that we need to look at is our children look different. They, after being treated, there are lots of different ways that they can look different. Some of them have growth retardation, some of them are just really large. They eat a lot, the weight management becomes a problem, they have scars and hair loss, and that is your expertise.
Yes. I have a flyer.
And that's Lauren.
Oh, yes, I'm Lauren. I'm one of the neuropsychology interns. So, I have a flyer that's out there available for you, but I'll just kind of run through like what I was outlining in that flyer. But basically, a lot of what kids are going through, especially at the ages of like 12 to 18, but even earlier, starting at 6 years old, is when we start to form a sense of self and like body image and perspective about how we look and what society deems as, like desirable and maybe a little bit different. And then by the time we're getting into like middle school, high school is when there's a lot of identity development occurring. And so, you know, for our kids that are like kind of going to be looking maybe a little bit different, that's particularly important to them, and that's something that's going to be a challenge potentially for them to navigate how they look compared to their peers. And so Leslie's going to hand out this flyer, but one of the things that we can do to start working with them is kind of helping them navigate like a self-image with like their unique needs. So for some kids it's like scars and wanting to hide like hair loss or surgical scars. And so how do we do that? You know, for especially girls, like that could be something as simple as like a wig. It could be head scarves and like learning how to tie different knots and make it fun and exciting, like do something colorful. Like these are kids, they want something bright and fun. This could also be like fun hats. It could be large glasses that are kind of in style now that like hide the fact that you might not have eyebrows, or something that's like more engaging, something that's physically like different and fun, but not in a way that makes them feel different from their peers in like a standout negative way that they might be feeling. So there's a lot of other things that we can be doing to like enhance just like self-esteem in general. So one of the things is keeping them like physically fit and active, getting them involved in something that they can feel positive about. So this could be tutoring like littler kids and making them feel like they have a way of showing their strengths. Doing community service is another one. That's something that's getting them to do something that's showing that they still have like all of these things that they can do, rather than focusing on things that they maybe can't do or haven't been able to do. And then with appearance also, like makeup, you know, I know it's like for some kids, like it might be a little bit early, but you know, starting off with something that's just like fun and can be exciting for them to start playing around with like self-image in a positive way, rather than always focusing on hiding. We can focus on enhancing. And so I also included a link to a website that has videos of other kids who have had brain tumors talking about what it's like, and so they can have like kind of that peer interaction, seeing kids who have gone through what they've gone through, because you know, in our school systems we might not always have other peers that have gone through similar things. So being able to see somebody who has, talking about their experience, can also be a way to feel more connected to a community and feel less different.
And then we also, the other component is when our children go back, we want to look at what the educational capacity is. There's a huge difference between intellectual ability and intellectual, you know, the intellectual functioning and intellectual capacity. Most of our children that have had some sort of chronic disease and have been in treatment for a while don't have the same exposure, and they don't have the same opportunities to develop as well. So latent cognitive ability is hidden, and it's your experience that you see. And we find most of our children have been in long-term treatment actually perform a lot lower on the initial IQ test, not because when we're testing them later and we've done these wonderful rehabilitations, we just miraculously fix them. And I've always said, you know, I'm amazing how I can test someone right at the beginning after surgery or treatment, and then several years later test them and their IQ's gone up by 20 points and I can fix it. You know, it's my bad joke. It's really what's happened is during that time, the exposure and the experiences increase, and you're providing the child with a lot more opportunities to engage in everyday activities that increases cognitive, just your overall awareness, which is what we measure on IQ tests. It's not so much, on an IQ test, you only perform as well as the experiences you've had, because that's what the IQ tests are geared towards measuring. It doesn't measure innate intelligence, although we love you to believe otherwise. And so any child that's actually had lesser opportunities to participate in activities that provide them with enrichment opportunities will perform poorer on IQ tests. The isolation associated with bone marrow transplants, the sick children, parents don't talk to sick children as much because you're so concerned about your child's welfare that you have your own burden to carry. And you're trying to protect your child by not showing your child how worried you are. And we do that by being silent. Or in my case, I just talk a lot. but I'll talk about the weather and everything else that doesn't matter. And so those things that you'd normally say is, oh, look at that, look at the wall. Attached to the wall's a door or a window. The things that help your child understand concepts and how things fit together, we miss that. And when the child's starting to recover, one of the things that we often say is increase those opportunities for your child to learn that. There's a whole lot more about executive functioning and intellectual functioning. Jackie's going to talk to you about that.
Okay, so my name is Jackie. Nice to meet all of you. So I am currently a doctoral student at FIU, and our Center for Children and Families, these are the pamphlets that are out front, have lots of different services for children that are having difficulties in school, at home, with peers. The main focus that FIU does is on ADHD treatment. So in ADHD, a child with ADHD has difficulties with attention as well as difficulties with controlling impulsive behaviors. Currently the CDC says that approximately 10 to 11% of children in the United States have ADHD. So in a typical class in South Florida that has 30 kids, approximately 3 of them will have ADHD. So in these classrooms, children are having difficulties learning, difficulties socializing and interacting with peers. They're often the ones that the teachers kind of spend the least amount of time with, unless you have a really dedicated teacher that puts in the extra effort. So for children that are having these types of difficulties, there's lots of evidence-based treatments that work, such as having behavioral management techniques, using reward charts, and managing behavior. That's the most critical component. So saying something like, here is the reward, and if this behavior is not implemented, then follow through with an immediate consequence. The main important thing is consistency with treating ADHD. In addition to that, there's lots of school accommodations that can be done. So 504 plans, individualized education plans, which Leslie can speak more about after. But it's giving the child the behavioral management techniques, knowing how to behave in certain situations and in different contexts, how to interact with peers appropriately, and then more of the school accommodations come and help with the attention deficits that they may be having. So as Reshma was saying, these accommodations will bring your child more to an equal level playing field versus being at a little bit of a deficit in the classroom. So I think Leslie can mention more about the school accommodations.
The important thing about the school accommodations are that we want to make these kids even with the rest of the group. Most of the time we think about school accommodations for children that have had a history of cognitive or developmental challenges since they were babies. Some of these kids began to have challenges when they were bigger, they were grown-ups. And they don't necessarily, or the parents most of the time don't necessarily think that they need help or need anything extra because they were great before. And we usually see with oncology patients physical changes, and we may see them a little bit slower than the others, but we don't necessarily think that this kid may develop any other cognitive deficits after treatment or whatever treatment they went through. Even being emotionally withdrawn because of the situation can create some cognitive changes in the kids. So we want to make sure that they have all the resources within the school system to be able to cope and to work the same way the other kids do. Most of the kids can apply for a 504 plan from baseline, but part of what we do through the neuropsychological assessment is to measure those changes between how this kid was before and how is he doing now, to provide them with specific recommendations that will help them get through school. I know I have heard that there's a stigma attached most of the times to getting accommodations, and some of the time they feel like they are different from the other. So that's why you need like an integrated approach where everyone can work with the kid, letting them know that this is just another step in their treatment and it's part of what they need to do. So these recommendations are going to be specific for each kid. Most of the time, they may include like additional time for doing tests.
So one of the, we have them tailored, and you have a 504 plan, and you have an IEP. So that's always the big question. An individualized education plan is only something that you would have if a child has difficulty meeting the basic academic requirements. So they would be reading, writing, math, auditory processing, nonverbal learning disabilities, and that's and motor skills. So if none of those are a problem, then the child does not get an IEP plan. So what they're going to be getting is a 504. Both of these are federally mandated. So children do get accommodations. There's one problem with an IEP plan. Although you get a lot, there's federal funding that is moved towards school districts for each child that gets an IEP plan to provide extra services and tutoring as needed, and speech and language therapy, occupational therapy, all those therapies. You age out of it when you finish from high school. A 504 plan doesn't have federal funds attached to it. So they're a lot easier to get, but it's part of the Disabilities Act. And so it translates, children that are on a 504 plan can continue to have this through college and into adulthood. So that's one of the big things that you need to consider when you're trying to get these. The problem with an IEP is, first of all, it's very difficult to get. Unless you can prove that the child has a learning disability, and intellectual disabilities don't fall into that category. So if you have a pre-existing intellectual disability or an acquired intellectual disability, you do not meet the requirements or the criteria for an individual education plan. Anything that's acquired then falls into the category of a 504. So most of our kids, oncology kids, if they didn't have a pre-existing learning difficulty, they probably will be on 504. The interpretation of a 504 plan, what's covered under a 504 plan and an IEP, differs across states, and then it differs across school districts. And then even in school districts, individual schools may have different ways of interpreting it. Private schools do not have to provide your child with an individual education plan, and they do not have to do a 504 plan. Neither one of those fall within the mandate of those schools. So if your child's at a private school and they are getting an IEP or a 504 plan in place, that's a courtesy of the school system, because they don't fall under the same federal mandate. The types of things that you can get with either one of those plans are extended times. Everybody's heard about those. Those are the common ones we know. Big ones that I like people to know is that if a child can't hear properly, if you've got any kind of a hearing compromise, which we see a lot with different types of chemotherapy and radiation, you can actually ask for audio acoustics in the classroom. And they can wire up the classroom so that the sound is amplified. There's multiple different systems where the one that I like the best is where the teacher has one receiver. It's a dual system. The teacher has one and the child has one. And it's just the two-way process. And as the teacher moves, it moves with the child, and it doesn't become so overwhelming. And they can take it from class to class. So if you have the classroom all set up, you have to use that same wired room. It costs about $5,000 a room to wire up. So if you're going to pay for it, schools are very willing to have them. Most of us can't pay to have our schools wired. This is a cheaper option. The other one that's really good to know that's available are for visual impairments. If you can't see properly and you have any kind of visual compromise, the Lighthouse Foundation in Miami is one of the best places I know in the country that provides a lot of alternative strategies and devices. They have occupational therapists that help with visual training and visual tracking, any kind of compromised vision, so the Lighthouse would be the place I'd go to. The things that we often see would be occupational therapy is a recommendation that we make and we want because of fine motor skills. And we say for fine motor skills, but occupational therapy also helps with adaptive functioning and everyday living skills. Just knowing where the lay of the land is, how to put on your jacket, you know, simple things like, okay, can I put my right shoe on my right foot and my left shoe on my left foot? The little things that help you figure out how to go through everyday life. Pulling up zips, putting on buttons, that's where the occupational therapy comes in. Speech therapy is important, not only because they'll help with articulation problems and language and, you know, just social conversation, social praxis, but speech therapy also helps with teaching children how to enter and exit social environments. Something that doesn't come very naturally to a child that's been surrounded by adults who cater to every woman fancy of their child. When we're caring for children that are chronically ill, we tolerate a lot that we wouldn't in any other child. And we're a lot more forgiving. And the rules, we actually do them a disservice because we don't put in the appropriate boundaries. And when they're entering the world again, they have to learn that. They have to learn what no means, how to actually listen to what someone else feels and how they feel. Because for a large part of the time, the world's theirs. And that's very egocentric. And that is your cue.
So parenting can be complicated when you are a parent of a child who is ill. Often the natural tendency is to kind of...
And that's Goalie, sorry.
Yes, sorry. My name is Goalie. I'm one of the neuropsychology interns. And so in regards to parenting, our natural instinct when our child is, you know, hurt or not feeling well is to cater to their needs, say yes more than we often would if it was a typical day. And so when doing that consistently, the child then learns that when I ask something, the demand is always requested, or the request is always, you know, provided to me. And so when you change and you shift to a normal setting or a typical setting, then any kind of change or fluctuation in that creates upsets, more tantrums, stressful experiences in itself. Even if the child might not articulate that specifically, they're internalizing that, and then therefore they might have more upsets. And that might look like full-blown tantrums. Some children might withdraw. And so what is really critical and useful to know as a parent is to kind of maintain some consistency in how you would respond to a child's needs. So that means limit setting. If you have specific time for iPad or technology, which children often love, creating some kind of plan or behavior kind of model where they ask for something and then you respond, maybe not always consistently yes. So that could be time limits. You can have it for 30 minutes. If they do have an upset after the time is done, you kind of stay listen, and that might be and look like validating, reflecting, but maintaining the boundary. If you respond every time a child has a tantrum, they then learn, if I express my upset this way, I get the kind of thing I need, the desired response. And so it's really important to maintain those limits. Also, you know, considering that children are experiencing a lot of stressful situation and a lot of confusion, and it's difficult to verbalize those feelings. Play is often very healing. And so we often encourage parents to utilize something I like to call special time. And that's just kind of maybe a set amount of time that you explicitly express that is, you know, one-on-one time with me and you, that they then direct the activity of choice. Physical activity is usually most regulating, but what's happening internally for this child, and if you think about it, our front of our brain regulates our behaviors and our problem-solving skills. When we're under stress, it can be hard to think. It can be hard to problem solve. Sometimes we might ourselves have mini tantrums as adults. So children don't have their frontal lobes or their front of brain as developed as we do,
And so they have even more difficulty regulating their behaviors when they're under stress. Therefore, we kind of have to be that regulating model for them. And that would include, again, reflection and validation, but also noticing the cues when they're moody, irritable, tantruming, to then engage them in some kind of play-based or regulating activity to then process the feeling. And it doesn't have to be them articulating like I'm sad or worried or everything's different, but just that, you know, I'm being attended to and getting one-on-one attention, and that, you know, I'm regulating in some way. When they kind of return to school routines, getting homework compliant and kind of maintaining some semblance of a routine can be difficult when kind of there wasn't as much structure before. Therefore, like chaining and shaping of behaviors is important, and what that looks like is creating kind of smaller goals to achieve a larger goal. So that would include, for example, if you want them to have their morning routine set before they go to school, and that includes getting up, getting dressed, brushing their teeth, eating their breakfast. It's a long laundry list of kind of behaviors you want them to do. And that could be very difficult if they're having kind of difficulty maintaining attention, kind of regulating their behaviors. So creating some kind of checklist and then breaking down the behaviors into smaller, kind of more achievable behaviors then increases motivation and success. So a useful tool to use is kind of some kind of whiteboard where you can kind of have your morning routine set and they can check it off as they go. Embedded rewards are always great. So for smaller behaviors that you want to reward and increase motivation and compliance, that could be like small homework assignments. Creating some kind of reward that you kind of agree upon with your child would be great. And then if you have a bigger kind of, let's say, goal, then a bigger reward, and that would be agreed upon with you and your child, would be motivating. And kind of being explicit and direct with what your demand is. So like, I would like you to finish your homework by 7 p.m. so that there's no confusion with what I want you to do, and it's direct. And then creating them the plan there, then therefore to be successful.
And at this point, we're going to answer your questions.